Good afternoon, and thank you very much, Michael. And I appreciate the opportunity to have a fantastic conversation with some terrific colleagues. Just to kick off the introductions, Michelle, would you mind starting us off? Tell us a little bit about yourself and your role.
Sure. Michelle Stansbury. I'm the Vice President of Innovation. I actually hold dual roles within overall our organization. So not only of our Center for Innovation, but also within IT of our corporate revenue cycle systems. Everyone on our innovation team holds these dual roles, which is what we believe has been our success. But Houston Methodist, of course, is 7 hospital systems with the Research Institute, physician organization, long-term acute care facility here within Houston, Texas.
Excellent. Thank you, Michelle. Shri, would you care to introduce yourself, please?
Thanks, Kristen. Thanks for having us, AI4. I'm founder CEO of H2O.ai, the open source machine learning platform, and we are here to democratize AI. And one of the core themes behind our initiatives into healthcare has been to further democratize health, reduce the cost of care, so more people can get access to better health. And I think we've been quite humbled by the COVID-19, and so super excited to announce that a lot of our team members, which include some of the top grandmasters in data science, have been diligently working to help the front lines and help healthcare systems and community systems like yours to both plan better and predict supply chain kind of better for PPE and others. And so we're super excited to be here and represent the AI community.
Excellent. And Tawnya?
Good morning, afternoon for some of you. Tawnya Infantino. I'm the Assistant Vice President for Digital Strategy and Delivery as part of the Digital and Innovation team for CommonSpirit Health. For those of you that don't know CommonSpirit Health, we used to be Dignity and Catholic Health Initiatives. We came together a little over a year ago to form one company that spans 21 states, over 140 acute care locations, as well as thousands of clinics, provider-based. So we are into providing care of every flavor, from skilled nursing to acute to ambulatory, you name it. And so, really primarily in my role, really responsible for forming those partnerships throughout the organization to really look at the solutions, the problems that we're trying to solve, as well as how we're going to do that. So, and what impact that we're expecting in the outcomes. So while technology is a very important part of it, the biggest part of it is what problems are we solving and what outcomes are we after, as this aligns with the strategy of our organization and the needs and expectations of our consumers and patients, which are very different than they used to be 5 years ago. Even after COVID, they're very different. So that's really my focus for the organization. Thank you, Chris. Back to you.
Well, thank you. Thank you all for a great introduction. As you know, my name is Chris Hutchins. I'm the Chief Data and Analytics Officer at Northwell Health, located on Long Island. So we have 23 hospitals that span across Long Island and metropolitan New York City. Over 800 outpatient facilities at this point. We are the largest private employer in the state of New York. And as of now, we have actually treated the far more COVID patients than any other organization in the country. I would prefer that wasn't a distinction that we had to talk about, but that's the state of things here in New York State and in the New York City area. So thank you all for tuning in, and I'm really excited to get into some great questions. We've got a great set of folks that come in here with unbelievable backgrounds and perspectives, so I want to just jump right in if I could. So the first question we have is, just from an observation standpoint, COVID appears to be a catalyst for accelerated technology and analytic adoption. Is that your experience to date, and how do you see AI adoption being impacted? Let's start with you, Tawnya.
Great. So absolutely, COVID-19 has been a catalyst. We were already working in this space prior, but what it really did was showed us just how disparate our data sets were. As we came together and as an organization, we had centralized data that was partial at best. And then we also had a very decentralized model in the rest of our data. And you can only solve for problems when you have good data. A great example is, if we wanted to do any modeling and prediction in terms of an in-surge of diagnoses based on symptoms that we're seeing, you kind of need to know that the diagnosis was COVID, right? So if you're not using the right ICD-10 codes, if you're not using all of the right markers and indicators, it's really hard to model accurately. So what it has done for us is really shown us the areas that we need to focus so that we can do good predictive modeling in the future, and identify the right triggers for the appropriate rates to make a big impact. So, with that, focusing very heavily on that digital health platform, how we bring that data, and we've had data scientists on staff for a while, and we are seeing an insurge of a surgence of the types of people that we'll need to employ in the future. We do also leverage a lot of different consulting partners, things along those lines for speed to market, but we're really looking at making this a core component of our organization.
Fantastic. Michelle, you want to weigh in on that?
Sure. I definitely agree with Tawnya that, data is key. And that's, been with our organization. We had actually started down a path. We've had an enterprise data warehouse for several years with some data scientists, and had been doing some things, but had started down the path of working with AWS and really bringing in the machine power that we needed, in order to analyze this data better. But I will tell you, during COVID, we actually saw some of our innovation initiatives that we had started really take off. One was within our virtual ICU and the platform that we were using as we started off. And I'll talk a little bit more about it later in one of the other questions, but clearly it was a true success for us and really better over to predict the deterioration of these patients, from a virtual perspective, and kind of having this remote monitoring that we put into place with a vendor that we were working with. But, as Tawnya would say, it's going to be key for any organization to really get a handle on their data and their data scientist, because what is now happened with COVID is everyone is clamoring for the information on what we can learn about what happened during this pandemic. And I will tell you, our researchers and our research institute are just hungry to be able to get a hold of all of the data that's being generated right now because of these patients we're taking care of.
Yes,
Michelle, are you finding?
Please
sorry, go ahead, Chris.
Oh,
I was just going to ask Michelle, are you finding that people are more ready to provide data and to open up data, whereas they weren't before? Yeah,
Yes.
We're seeing the same thing.
I will tell you, especially in the lab area, that was something it was kind of very closed. Very much we would share it kind of with ourselves. But now it's, lab data is very specific on what you absolutely need to be able to help determine and doing a lot of different predictions. And so, yes, we're now opening up that system a lot more to be able to share that data, within other platforms that then allows data scientists to be able to use it and better, facilitate the understanding of what we're trying. Everyone's trying to understand this patient population better and what happened and how can we better predict, and so that we don't have a big masses of patients that are, that flood with us all at once. So yes, I agree, Tawnya. It's more, everyone understands now the importance and why we need it. Who would have known that we would ever gone through a pandemic, right? But now that we have, how can we ever prevent it from happening again? And COVID's not, they say, it's not going away, not anytime soon. So the better that we can learn from this information, I think the better we'll be able to predict and not have this surge of patients that we've had now.
Sri, did you answer this, if you could address a couple of different aspects? So we're hearing a lot about the criticality of having your data prepared and ready. Could you talk a little bit about the readiness aspect as you're talking how this is impacting the things as you see them as well? I'm sure you're interacting with a lot of different organizations.
Absolutely. And I was actually also curious how Northwell has been dealing with the transformation. Likewise, I would love to hear
Yes.
in in line with what we heard from CommonSpirit in Houston.
Sure, there's a lot of similarities to the last point in terms of being willing to make data available. We had obviously a burning platform where we had to get a lot of answers relatively fast to be able to manage search. We are licensed for roughly about 3,000 beds, but we were adding roughly about 200 a day as we were approaching the apex. And so there was a handful of folks from across the organization that all had oversight of operational, financial, clinical, quality, number of different parts of the organization. We were having these touch points on the fly constantly, adjusting the models to try to make sure our operations folks understood, how many beds they need for ICU, how many ventilators they're going to need, how are we staffed, do we have enough PPE, and how are we managing our emergency services. In a very large network, that was really, really critical for us to have regular touch points. We had a lot of learnings with regard to how we've organized. We've gone by acquisition over a number of years, and a lot of our groups are on enterprise platforms, and the data structures are accessible. Some of them are not yet there. So we had to do a lot of things on the fly, working directly with some of the vendors to get critical data, to help understand operations and workflow in those parts of the organization. But it also was required from a state perspective. We had to report things to the Department of Health. Tons of lessons learned, agile development on steroids, I would say. I mean, having VPs and executives on the phone at 10 o'clock at night, dropping in and coming in and out of our meetings, and grabbing their staffs to add data elements to our feeds that typically would have been a political arm wrestling match for months, was happening in minutes on the fly, looking at the screen. I mean, amazing.
And these are the war stories of COVID-19 in the back end, right? The backroom war stories. We observed very similar mechanisms. Our experience with COVID-19 started in Wuhan. Our product's open source and widely used even in China and Asia. So we got pulled into some of the discussions early on how to do contact tracing from seafood stall to which cities. So we were quite worried about how the disparate health systems in the US would react to it. So to some degree, we were trying to get our teams quickly engaged with some of the community health systems who are fortunately our customers and have been working with our platforms here, between testing and supply chain for essentials such as beds, nurses, staffing of nurses, to kind of how to predict the number of ventilators. These were the early problems we looked at, how the peaks would look like between different counties. There's such localized response to this pandemic and this time. And so even Santa Clara was different from San Francisco, much like Manhattan was different from Brooklyn and Bronx. And I think that kind of localized segmentation and modeling was really difficult because historical data, I mean, we all know that all models are wrong. Some models are useful, but I think in this particular case, it was actually more so, and you had to learn from interpreting the model. So much more simpler methods were used across the board, so we can learn from its mistakes and adapt the next week or the next day. We saw a lot of, obviously telehealth has become much more open, so we could, and some of the Asian reactions to that using WhatsApp or WeChat kind of ways of becoming, giving help to customers who are patients who are not coming to the hospitals, and the efficacy of the telehealth. ICU transfers was one of the common problems we looked at before from a sepsis and other mindset, but I think more so now, predicting how many people will be hospitalized so that the drug companies can be prepared with the right amount of supplies. These were some of the problems we're looking at. We also beginning to see the contact tracing use cases kick in, which we found that shutting down schools had the biggest impact in terms of measures that communities have taken, and that dramatically had the more people are talking about flattening the curve. And I agree with Tawnya and Michelle that bringing alternative data sets, especially public data sets around smoking or age of populations, comorbidities, all of that alternative data set became a very important aspect of modeling. And I think that's kind of where we came in with a third-party perspective. But I think the problem is far from gone, and I think we are essentially on the cusp of how to predict the second potential. How does fall look like? I think a lot of eyes around the data scientists to see how we can bring that together. A lot of kind of, I would say, healthcare systems have come to kind of grips to the point that they need to modernize, and I call up BC as before COVID, right? Sort of, and since then, AI used to be a good thing to do, an innovative thing to do, but now it's become must-have and an essential tool chain on how we drive forward.
Yeah, I think our reality has dramatically been impacted for the foreseeable future. Actually, looking at a couple of the questions that are coming in, I think one of the ones that I'd like to kind of tee up as we start getting into some use cases. I see a question with regard to, how we'll be able to predict things in the future using these type of capabilities. But I think from a real life scenario that I'm dealing with right now, was just on a call with a bunch of my colleagues, one who is an infectious disease expert. And I think there's probably a lot of ways, and I'd love to hear from my colleagues here with regard to how they're thinking that AI and machine learning might help to alert us that there's things to pay attention to with regard to maybe a resurgence or whatever. But I think the one thing I will say from the medical professionals that I'm hearing from at the moment, there is so much that we don't know around how this disease progresses and it morphs, that it's kind of hard to understand how we'll be able to leverage this technology in meaningful ways at the moment that we're in right now. It doesn't mean that there aren't any. I'm sure, quite honestly, there will be. The trick will be looking at, what are the indicators that we can prove are really, really meaningful or early enough that we can maybe be proactive on some level than we were, certainly in how this kind of hit us, and overnight we're in crisis mode. Any thoughts about that as we start to think about some use cases as well?
Well, I'll go ahead. This is Michelle. Yeah, it's everyone's trying to be nice. I agree with you, Chris. It's probably the $100 question or $1,000, whatever you want to call it, of how can we better utilize the data that we have today to better understand how we can predict, when something like this, can happen. I do think our data scientists and using all the data now that we're going to have that has come out of this pandemic, to better help us. I will tell you at Houston Methodist, you just talking use cases, it's, the one use case that we had where, it was beneficial was our virtual ICU that we had stood up. We had planned to roll it out, kind of in a 2-year fashion across all of our institutions. But, the platform that we chose, it was extremely beneficial. One, it was the, algorithms associated within the platform that, we helped with development overall with the organization, to help us better determine the deterioration of these patients. But then also, the virtual aspect of it, it was able for, our hospitalists and some of our physicians not to have to really go into these rooms to really take a look and see what was going on with these patients. Because, it takes time to gown up. It takes time to be able to put in all the PPE. And sometimes you just need to be able to get to the data and look at the patient and see what's going on. But, kind of in the future, I would say, for us at Houston Methodist, we had been working we had actually tried with one vendor on a product for ED surge, and it really trying to determine, when the surges were going to be coming into the ED, which I think is going to be very prevalent as we kind of go forward and seeing what's happening with some of these patients. And so we do, while that one product that we had didn't do so well, we learned a lot from it, and have a different product that we are installing and we'll be bringing up here probably within the next couple of months that hopefully will help, if during the fall, which I know we're all hoping that we're not going to see another, spike in anything, but you never know. But I do believe kind of with the data, with things like we have with, ED surge prediction and some of the other data that we're going to come out of this will be able to help us in the future.
And non-COVID related, so not as sexy of a use case, but very much a problem in the healthcare industry are no-shows. So when you think about other industries like travel, so you have your airlines that double book quite often, based on some of this technology so that they can predict, hey, we're probably going to have so many cancellations so that their flights are still full. You can employ that same model in the clinic setting, which is what we've done. And we piloted it just primarily in Arizona. And with a very small pilot, we were already looking at $500K annually in savings because we were able to double book and keep those schedules full. That was a very small pilot. So when you think about that, you've got a $10 million problem in no-shows, and just one use case, one very small, was able to make a $500,000 impact. As you look at doing that across the organization, when you're looking to, run a tight business, which healthcare is business as well as it is taking care of people. Healthy people are better off for all of us. But when they do have to come into the clinics, making sure that those schedules full are incredibly important. So, that's something that we tested out. We're looking to, expand that in this upcoming year. But it's really important to try those use cases, start small, see what kind of impact that you make, and then build on those as you see things that are working. And Michelle, that was a great example. Hey, sometimes it doesn't work, but sometimes it really does. And to zero in on those very quickly without getting too difficult and complicated, as Sheree was talking about earlier, is incredibly important. So experiment a little bit.
Right. Sheree, you talked a little bit about contact tracing and some things that you've done in Wuhan, but I'd be curious, if there's a favorite use case that you've seen that's been really effective, could you tell us a little bit about that?
Yeah, I think ICU transfers is a really interesting one. About 50% of accidental errors are caused by mispredicting that. So triaging, a lot of ability to learn. Multi-hospitals is a common theme, and people have not modeled how the demand is across multiple units, mostly because they're mostly hyperlocal, and cluster outbreaks. That's one problem we looked at, especially if the proximity to senior citizen homes, nursing homes. That would have reasonable impact on the rate of the surge. We've been looking at a lot of, I think overbooking was Tawnya mentioned a very interesting, simple use case that's very effective. We've seen one of our community users, HCA, for example, they combined 160 hospitals, models from all of those hospitals to predict sepsis, which is actually a very big problem in the space. I think what happens to predicting the patient, kind of what state, whether they will need dialysis or they need a kidney transplant, or it's very likely to be a fatal situation years down the lane. I think those are kind of the problems that are the kind of the cool use cases. But the typical use case we see in hospitals is just operational efficiency. It's sort of how do we drive towards excellence there? How do we drive the typical problems? That's how to make sure that they're not paying the vendor twice, or the boring use cases happen to have the maximum output as well. In staffing, and predicting if a great physician will be changing jobs. Those are kind of the simple problems that seem to be kind of the most kind of impact for the bottom line of the hospitals. And I think typically looking at hospitals just like any other great business and how to kind of improve it across the board. CIOs have been tasked to kind of reduce costs, but it's mostly to improve efficiency and excellence, and I think that's kind of this. I'm sure you're seeing something similar, Chris.
Yeah, I think the primary use cases that I'm familiar with that we've been working on are really around some pretty common challenges that most healthcare systems are working on, predicting risk for readmission. In this particular case, we're trying to predict things that are on the fly, which is really complex. But we're looking at a ton of information on patient experience to try to predict, whether we're likely to get a good rating from a patient based on their historical experiences with us. Which a lot of fascinating things. There's a lot of different levers that we can pull that'll impact patient experience, but we're trying to really understand the different types of interactions that folks have with the health system, and what are the things that are most impactful. And I know our data science team is being tasked with probably more things than they can juggle at the moment, because everyone wants to know, is there going to be a resurgence, and if it's going to happen, when, and how much more of an impact are we going to see from an infection rate or mortality rate or hospitalization rate than what we saw at the apex over the last several weeks. So a lot of things to be determined, but I wish my crystal ball was better than anyone else's, but I'm afraid we're all kind of going to have to work through this together. Everyone's going to be earning their keep for a good while here, I'm afraid, just trying to deal with this one particular area of focus. There's a couple of different things that I've been seeing, and we'll jump into some strategic things in a second, but I just wanted to touch on it, because I think one of the things people are thinking about here is the use of external data, as oftentimes if people are asymptomatic, we may not even know that we should be looking at them yet. I can only tell you from my own personal experience working with my colleagues here in New York, it's a significant challenge to get our hands on data that could be helpful for us. There's information that's collected by the state and local governments that theoretically might have some impact and could have utility to help us understand if there's opportunities to get ahead of things. But it's a big challenge. I think it's probably everywhere, let alone, we have it in the US, and I'm sure that depending on the political climates and the adoption rates for information sharing around the world, I think probably everyone's in the same boat. Sadly, we got a long ways to go. We're happy to share on social media, but we don't want to enable our healthcare providers to have the information that would help in this case. Love to hear your thoughts on that.
Yeah, I would agree with you, Chris. I mean, we have a long ways to go when it comes to data sharing, and you're absolutely right. I think social media, we will share everything in our personal lives on social media, but we're all hesitant when it comes to sharing, medical data or anything else that has to do, which is probably the most important thing that we could be sharing right now across our country, and anyone else, to really be able to better understand patient populations. Do I think it's going to drastically change overnight because of COVID? No, I don't. Will it maybe help to facilitate better conversations about how we can go about doing it? Yes, I do agree that. And I think our data scientists and some of our, top officials are probably going to better understand why it's so important now that we do begin to start to break down those barriers. Because we'll never get to where we all want to be, which is how do we better predict, these things occurring, not only just in the United States, but in the world, that if we don't start sharing to be able to help build in those predictive models and things, we won't ever get to where we want to be. I wish I had the magic answer that would be able to make individuals understand, but I don't think any of us do that are on this call, or even the ones participating. Hopefully just we're going to learn that those barriers are going to have to start to come down.
Yeah, hopefully people like us are able to influence our organizations that, while we have the opportunity for patient engagement like never before, let's get creative to educate them to the benefits of information sharing and get the right levels of consenting going on so people can help us to help them.
Exactly.
I think there's a combination of public data sources as well, right? Sort of data quality itself is that question. At a lot of places, like in California, there is a backlog in the screening and testing data, and I think that's slowly that backlog has been cleared, and now you see more different kind of case history stories. I think there's a bunch of we are going back and back testing some of the SEER models to see if how good and how effective or ineffective they were. Alongside the pandemic, there was an epidemic of dashboards, and I think some of them were not really based on strong science. So trying to go back and revalidate and back test our understanding of how the model, how the virus is spreading, and what are the various modalities that cause much more severe reaction to it. And those are the kind of things that we are beginning to kind of understand more in the case of resurgence. Alternative data sets, I think that's been something that we collected a lot of some of our data scientists collected data sets, published them in Kaggle and other places where they now become part, just like the Johns Hopkins and the Volvometer. We're now able to kind of augment to them additional demand sensing. So some of our customers are predicting kind of cleaning supplies, right, sort of in a different industry. And so they need a much more tighter understanding of how much Harpic will be sold or how much Dettol. And so that's similar thinking we're bringing it to the same place. So we're kind of trying to bring similar kind of,
So the question I want to get into the strategy conversation quite a bit. Okay, so has AI been included your company strategy? Is it budgeted explicitly or part of another program like IT, analytics, or innovation? I think this is an interesting one if we're talking about the state of AI. I think a couple of questions that I saw that folks are asking were really kind of pointing to this, in that there's a lot of things that have to be in place in order for you to do predictive analytics. So in times past, like I think someone mentioned, why weren't we doing some of this stuff during the Ebola outbreak, et cetera? Healthcare organizations, for the most part, are nonprofit, and we have only so many slices of pie, and we have to really prioritize things and make some hard decisions that oftentimes have meant that analytics and some of these innovative technologies don't get prioritized ahead of some of the critical systems to keep the operations moving, et cetera. But there is a shift happening for sure. I'd love to hear from each of you, how this is really being handled in your organization, where it fits in, et cetera. So,
Chris, I'll start on this one. It's a little bit of an interesting path for us because, we have two different flavors, if you will. We have our operational that we were just talking about a little while ago when it comes to no-shows. And then we also have our clinical, which you touched upon, Chris. We have a few products and partnerships that we've put into place to really take a look at, asthma as an example. How do you reduce those readmissions? How do you reduce ED visits? How do you reduce admissions in general? How do you predict an asthmatic outbreak before it happens? So, when you look at it two-pronged that way, to separate it into its own budget, if you will, or its own strategy, makes that a little bit challenging. So what we've chosen to do is really fold that into our overall strategy when it comes to how we are bettering the company through digital in general. And coupled very tightly with our data group. Data governance is a big piece of this that you have to fold in. So really it's a combination of several teams and several different areas coming together collaboratively and in partnership to bring these solutions as a whole. So yes, we're focusing, and there are certain things that are called out explicitly in budget, but not as an entity on its own. It's embedded in a lot of different places.
If I could, do you do budgeting for proof of concept, things at that level? Specific projects?
In a generalized way, Yes. So we have innovation budget. We have a certain talk about capacity-based funding. We have a specific amount of capacity that we have set aside for these types of things. But then we also have budget set aside for specifics, some of the tried and true that we know that we need to expand. So once we have done a proof of concept, once we have done a pilot, once we have really a proof of value, that's when we move into the official budget and it becomes a line item then part of innovation.
Michelle, same question to you.
Yeah, I would say it's, it's been a strategy of ours, as I told you, before COVID hit. And because we have a research institute, it's probably even more important. I mean, our researchers, our data scientists, we had a project, the project's still going on, to do true analytics, AI, predictive models, all of that. It's not cheap. And we all know that. And you're absolutely right that, it does have to compare to overall hospital operations, how you're taking care of patients. But our organization with, clearly our senior leadership that's from our research and also our analytics group really saw a need that, we have a platform and the way to be able not only to take our own data, but to be able to take in a lot of external data as well, to be able to use that information. So, it is a strategic initiative of ours. We do have the budget for it. It kind of got slowed down a little bit because of what we were doing with COVID. And I agree with you, Chris, and the reports and things and how everything had to change at just an hourly basis was amazing. And the work associated with that, hopefully after this is all over with, our customers don't assume that we'll stay at that same pace, in producing things. But it was amazing and really appreciative of our organization, and how that they have adopted and try to understand that what we need to do with data and really moving forward. We do on our innovation side, that's how we learned over on the ED Surge. We have our own separate budget. We do pilot a lot of things, to be able to help determine how can we help solve our problems. And I have said, innovation's different for everyone. I mean, hopefully, my problems aren't your problems, and, we're being able to share a lot of things that we're learning in that space with each other. So we're able to quickly get through some of these newer technologies and in this digital space to be able to provide our patients what we need to do.
And Michelle, we have a new saying, it's called the COVID speed. People are saying, it's a little sad, but
it's not
that's what people are saying.
Yeah, I have a feeling that COVID speed is going to be something that everyone wants to continue.
Mm-hmm.
Yes, well, we're going to need the same administrative air cover then.
No, that's a good. No, I think data is a team sport, right? Sort of one of the things that I would like to mention is that while we find ourselves partnering very closely with our healthcare customers, and we think of ourselves more like the kind of Tenzing Sherpas of the world who climb up the mountain up and down with our customers, we find that each one of them have different mountains to climb, right? In many ways, AI is a cultural transformation as much as a technology transformation. What COVID-19 kind of almost it made it mandatory for all of us to be digital workers first and then analog. So I think it got us to rethink some of those cultural kind of hurdles of change management in a very abrupt fashion. I think that has historically we would see different companies, different customers have different centers of excellence, and the best data scientist is in a group that doesn't have the budgets to do anything or the willpower to do much of the change. So I think now what this done is bring the best of breed to one place and start bringing that change across the organization much more faster. So part of it's COVID-19, part of the incredible agility with which healthcare systems have revamped themselves and started looking at the problem face on and start bringing those changes. I think it's incredible to see how quickly the health systems across the U.S. have reacted to this, and and have now plans for bringing this change at a longer term. I think there's been a temporary, I would say, suspension of, and there are some questions about privacy in the Q&A section. I think there's a bit of a temporary suspension of reality there, but I think it's probably going to come back with a just as level of strength as it had before. My general thinking there is gone by the principle that if one of our names is in a row of any table, no matter where that table is stored, whether it's in the cloud, Google, or Facebook, or in a healthcare system, we own that data, and as a result, we reserve the right to give it for good scientific research or for a nonprofit to make improvements, but not the other way around. Or so it becomes a property right of the owner of the data. As a result, he can rent it or use it or own the kind of the usage of it. So I think that general principle is generally where the world is headed, and I think we'll see just greater benefits of scientific research from this effect.
Yeah. So I think we're getting close to the end of our time, but there's a couple of things that I'm seeing in the questions with regard to some of the capabilities that either may already be in place or you're enabling, or in my case, I can tell you it's things that are probably coming down the road. One of which is particular use cases for computer vision or video analytics. You guys have any of those types of things you're doing, or you guys would think that are coming up in the future?
I mean, I would just tell you, on the video side of things, I don't know if, kind of the analytics, but and as Reed just mentioned that it was virtual health as a whole, I think will never go back the way it was before. I think it was, something that everyone thought was nice. Some of us were doing it, not well adopted by some of our clinicians, but now it's just exploded. And, for us, it exploded like you would not believe. And, one, it'll be interesting to see as this sort of calm down, what's going to be the new normal. But I would say not only it helped us from a clinical perspective, but it also helped us from a patient engagement. We ended up giving out iPads to most of our, in the COVID units. I mean, one that was to be able to help with overall in our virtual ICU, but also help from just an engagement perspective of having patients be able to talk with their family members because they could not get in to come see them. So I think video in general is here to stay. How it's going to really change and how this will be, for remote institutions and how you take care of patients in that aspect, how is from, the virtual ICUs that are going to be popping up and really occurring. I know, as I told you, it was a 2-year project for us. We plan on instituting it across all of our institutions by the end of this year to be able to help facilitate in that process. So it's interesting to see just what's going to happen from COVID, from this, that's going to become all of our new norms.
Yeah, I think the explosion in telehealth now that I think it's going to be sanctioned and compensated or reimbursed for. I'm curious to see what we're going to be asked to do from an analytics perspective on that front. I'm not thinking about it at the moment because I can't process it.
Well, I think the big key piece after that will be what is reimbursement going to look like for all of us.
Yeah.
We are having to completely adjust our business models all around all around virtual, not just video, but also asynchronous care, also texting, also the entire paradigm has shifted. And it's unfortunate that for us, it was COVID that has forced that shift. If you look at fintech, it was the internet when that came to be that really spawned the ability to do mobile banking. ATMs were back in the 1960s. That's where they started, but nothing exploded until it had an enabler or a catalyst. And that's what's happened to us here with COVID. We now have a catalyst that is spurring us into a complete paradigm shift. And so regulation, business models, reimbursement, all of those things have to catch up with it. And that's where we're putting our focus on how do we make this our new norm, because patients are asking for it. And so we need to be able to respond.
I think in many ways, it's the continued democratization of care. And so how do we make it faster, cheaper, easier to do it? How do we make it the patient experience, as you mentioned, Chris? anyone who has, I mean, I had to spend 3 weeks in helping my mother-in-law in an ICU. Anyone who has been there knows that a kind of a more digital version of an ICU where all the various modalities are taken care of in a more scientific fashion. I think it's really the coming of the future, where a lot of the hospitals' IT systems and technologies have been waiting to bring this change. I spoke to another nonprofit which is looking at ventilator as a service. So no hospital buys the ventilator, but it's able to supply, adjust the supply and demand. There's a lot of things that we can put in now which can help our future generations fight a pandemic more effectively. And I think both from the public health data systems standpoint to even private and regular day-to-day healthcare. A lot of our customers are now beginning to ask which electives that have been postponed will become more popular so they can have the right kind of physicians to support them and the right kind of staff.
Right.
And I think, unfortunately, COVID-19 will drain a lot of their health systems of their strong financial basis as well. So I think this is the time to kind of really look at how to make things faster, cheaper, easier, and democratized. Will become a necessity, not a good to have.
All right.
We're definitely focusing really heavily in the last couple of weeks on our recovery strategy and looking at getting the ambulatory network restarted and using telehealth, everything at our disposal to re-engage the communities to make sure that we're providing care.
All right. Thanks, Chris. All right. Well, thank you so much to the four of you. I must say, even though it's a shit show with COVID, I feel good having leaders like you at the helm. So thank you. And yeah, thanks for joining here. I'm going to put it on gallery view so everyone can see you, and then we'll clap for them. Trust me, you have hundreds of people clapping right now. And with that, I'll bid you adieu. What I'll do is I'll make the four of you.
I would add, Michael, that the claps, the front line that was fighting for us in COVID deserves all the claps.
Agree.
I agree. So we can clap for them, all of us. Come on. The front line. Thank you, Shri. I totally agree. All right. And so with that, we're going to shift over to our pharma panel. So I'm going to make each one of you an attendee status now. You can depart or stick around. Thank you very much. And yeah, I'll talk to all four of you soon through email, I'm sure. Thanks so much for being here.
Thanks very much, everyone.
Thank you.
Thanks for having me.
And Tawnya.